Gentlemen, thank you so much. Mr. Adelman and Dr. Shea, I think that we all applaud you for your innovation in bringing that here to Michigan, and also Mr. Lackman, we also appreciated you making the legal aspects so consumable and engaging for us to understand. So thank you so much. Our next panel is going to take a look at how we apply all of the concepts we've been talking about for the last couple of days into a handful of very special conditions. And I would be actually quite surprised if there was anyone in the room that wasn't somehow impacted directly or indirectly by opioids, Alzheimer's, or autism. So I think this will be a great session, and it will be moderated by Dr. Tim Pletcher. That's not Tim Pletcher. This is Dr. Tom Stevenson.
That was my line. Good afternoon, everybody. I am Dr. Tom Stevenson. I am the Director of Medical Informatics for MaryAnne, and I'm going to be your moderator for the next hour. So thank you for attending our panel session, Leveraging HIT to Enable Better Care for Special Conditions. It would be tough to find 3 more visible and complex conditions as opioids, autism, and Alzheimer's. I'd like to introduce our speakers in reverse order. We'll start with Aaron Seib. Aaron serves as the CEO of the National Association for Trusted Exchange, or NATE. Mr. Seib is passionate about health information exchange and has made the realization of a learning health system his professional life's ambition since his son was diagnosed with autism in 2004. Mr. Seib is currently engaged with a number of projects that promise to take the nation one step closer by realizing this ambition. I've had the pleasure to work with Aaron for the last year or so, and I'm sure you're going to enjoy his talk. Our second speaker is MaryAnne Sterling. MaryAnne was a caregiver and healthcare advocate for her parents for 20+ years. She's a renowned speaker and educator on family caregiver issues and dementia, and she and her husband have 3 out of 4 parents impacted by the disease. She's an outspoken advocate of person-centered healthcare, transformation, family caregiver empowerment, and Alzheimer's education. MaryAnne also serves as patient research partner and ambassador for the Patient-Centered Outcomes Research Institute, or PCORI, and is an advisor for the National Alzheimer's and Dementia Patient and Caregiver-Powered Research Network. I've witnessed many of my patients and their families struggle with this disease, and actually I have a strong family history of Alzheimer's in my family as well, so I will be listening intently. And she's promised I'm going to like what I hear. Our first speaker is Dr. David Neff. David has been a longtime colleague of mine. We are both DOs. We're both family physicians. We both went to MSU-COM and became involved in HIT and HIE. Interesting thing about HIT and HIE, there's a lot of different paths out there, and we took divergent ones. But the nice thing about this, it's a rather small community, so we've had a chance to be able to cross paths on a number of occasions. He is the new Chief Medical Director in the Office of Medical Affairs, Medical Services Administration, Michigan Department of Health and Human Services. I would hate to have to say that about myself all the time. Director of Medical Informatics is much easier. Where he manages the clinical team for Michigan Medicaid. He has been involved with large-scale planning programs to address population health-related issues in the areas of cardiovascular disease, diabetes management, and opioid addiction since 2000. He has been studying the opioid mortality crisis since 2010 and has been a member of the MOA Presidential's ad hoc committee to address the crisis since it was formed in February of 2015. The initiative was recently recognized by the Michigan Society of Association Executives with the Diamond Achievement Award for Best Governmental Relations Project on combating the opioid crisis. Dr. Neff has been with the Office of Medical Affairs since retiring from Merck & Company in 2014 as a strategy leader in global medical affairs. And he also sees patients, including those with recalcitrant chronic pain and/or opioid addiction. So, without further ado, Dr. Neff.
Thank you, Tom. It's a pleasure to be back to Lansing. Pleasure to be involved with our neediest population here in the state of Michigan, and a pleasure to be working with all of you in terms of exploring the next frontier in HIT. What I'd like to do today is be in a position to share with you one of the biggest clinical problems that we're trying to encounter that may be one of the largest man-made disasters across the country. What I'd like to do in terms of doing that is set the stage in terms of the magnitude of the problem nationally and here in Michigan, be able to share with you, give you a glimpse of the evolving strategy that's being developed here at the Michigan Department of Health and Human Services and within the executive branch, working with our legislators and our key professional societies. Part of this information has been developed over the last 2.5 years, and a lot of it is with ongoing conversations with internal and external stakeholders across the state. Here's the magnitude of the problem, especially in the last 2 years. We've known that this has been an issue for some time, especially since 1999. The key number to remember is 4x, 4 times more across the board with everything in terms of relationship, in terms of prescription of opioids, the availability of heroin, the increased number of emergency room visits, the increased number of people entering addiction programs. So as you can see here, there's been a steady rise until about 2012, and since 2013, you see a marked upstep or increase in any opioid mortality. Along with that, you see, along with the advent of medications that were converted to C2 and making it a little bit more difficult to prescribe, the opioid prescriptions have actually tapered off. But the market rise in the last 2 years and a couple years before that is actually heroin and synthetic opioids that are now on the market and being contaminated or diluted with heroin and or cocaine and or other substances and being administered through the vein, and more recently an increase in uptake with mechanisms like vaping. So these medicines or these illicit drugs can hit the brain within 7 seconds after being inhaled. So these are the major factors here. Too many opioids, 4x, too much heroin, 4x, a challenge and strain on our available people power to be able to address the system, across the state. And this is increasing the number of opioid overdoses and mortality. This schematic is actually developed by the National Governors Association and is one of the key sources where we've developed our information. What does it mean at home and in our emergency rooms and in our community? 91 Americans are dying every day. 1,000 people per day are being seen in the emergency room. Sometimes it's the prescription. Opioids, like I said, have increased 4-fold since 1999. Providers wrote nearly 250,000 opioid prescriptions in 2013. There's wide variation across the states, but the most common drugs, again, are methadone, which is used for opioid addiction, oxycodone, and hydrocodone. Unfortunately, after the prescription is fulfilled and there's too much supply available, it sits in a purse, in a glove compartment, or a medicine cabinet. 3/4 of these prescription opioids are obtained by end users for free, bought, or stolen, largely out of the prescriber's hands, and much of this was started for recreational purposes, and sometimes the chain begins as early as ages 12 or 13. Since 2010, the amount of heroin available on the street has quadrupled. Heroin is a part of a larger substance use problem in terms of using psychoactive drugs for initially recreational purposes, but then becomes a trap in terms of trying to manage craving in order to avoid withdrawal symptoms or to continue a high. Much more the former than the latter, though. As you can see on the right-hand side, if you've used an opioid painkiller and it hasn't been properly tapered, the increased risk is 40 times greater, much greater than cocaine, marijuana, and alcohol, which are also risk factors together. Well, what does it mean here in Michigan? It's a little over, under 1,800 patients are people, citizens, family members, friends, died in 2013. That was up 13%. And again, in 2015, our most recent statistic, they went up another 13%, which was an increase from 2014. Now, if you look carefully where I've drawn the line, you can see that Michigan sits, we're the 10th largest by population, but at 21 deaths per 100,000 in 2015, Michigan is number 15 in total number of deaths and among the top 13 states that have shown dramatic increases during our last statistical period. Here you can see over a 3-year period, a slightly lower number, 17.7 deaths per 100,000 citizens for total poisoning mortality rates, and that includes benzodiazepines, opioids, and other agents. And you can see with a dark red, bright red, where most of the mortality has occurred. You can see the beige counties followed by the light gray counties in terms of where most of this is occurring. Now, if you can imagine the public highway system, the largest density population areas, perhaps even university areas, you can see all the way from Monroe County all the way up to Sault Ste. Marie, across the Upper Peninsula, and then across I-94, I-96, and up 196 and US 31. And it gets slightly less as you go further north, but the Upper Peninsula is not devoid of this problem. For opioid mortality rates, it's 6.5 per 100,000. And you can see again, even here in the Tri-County area, dark red, highest mortality rates where many of us live here. You can also see it in Southeast Michigan and along the same geographic distribution that we discussed. Now, heroin has gone up dramatically and is catching up at 4 deaths per 100,000. And again, you see it more in the lower peninsula, but you also see it across the state. Now, what does this mean in terms of people using prescription opioids? And sharing with you data here just to put relative context in terms of the problem. In 2016, there were about 400,000 patients who were on 30 days of prescription opioids for Medicaid. Because I don't have the numbers for rest of state or for commercial and non-insurance, I just multiplied those by 3 and then added both of them up. You can see that about 1.6 million, roughly estimated, and looking further down, 115,000 patients were on 90 days in Medicaid, almost 22,000 were on a whole year, and then it dramatically drops off in 2016 for the number of people who were on it for 3 years. And again, 4x, you can begin to estimate the problem in terms of where it is in rest of state. So the key questions for us, both from a population health and how we manage individuals, are of this population for prescription opioids, who's at risk of dying from an overdose? How do we shrink the amount of opioid? How do we put 4x back into the bottle and get it back down to where we were 20 years ago? And then how do we decide if one should continue, if it's justified? How do they document it? And how do they bulletproof any liability they may have for continued use? Also, the other option would be to taper to a lower daily dose, decrease risk, taper off completely, increase the risk for withdrawal, or to taper to a point where treatment can shift to using medication-assisted therapy for opioid use disorder. And then how do we also decrease the diversion and illicit prescription opioid trafficking, both for heroin and prescription opioids? Well, this is what we're thinking. And we're using not only the National Governors Association, we're using the Association of State and Territorial Health Officials model, which is a pyramid where we look at primary prevention and then acute health event control and then public health practice paradigms. In terms of trying to be able to provide care from a preventative level, just don't go there, don't do that, or get off of it as soon as possible, all the way to life-saving measures, including that of naloxone, which was recently approved by standing order by our chief medical executive, Eden Wells. So it's available behind the counter for any friend or family member or even a patient who doesn't have insurance and wants to pay cash. That's the first step, save a life. We're also taking a population health approach to address the crisis through self-care, through learning, beginning with what we've been talking about for the last 2 days, community service programs, including schools and faith-based organizations, starting at primary care for when addiction becomes a problem or ongoing pain issues, through CMH and additional specialty care, all the way through inpatient detoxification. The other approach we're taking is embracing 4 major stakeholder groups to address individuals and the entire population at the same time. They require different strategies, but the fundamental basic backbone is having available information to make decisions at the point of care or in terms of trying to manage the herd or the entire population with the walls of one's practice all the way to the largest healthcare systems here in the state. We're looking at directly embracing providers, the health system at large, law enforcement and the judicial system, and community. And this is going to start at the community. It has to be in the fundamental local area where local people have knowledge and ability to broker change and change not only prescription habits, but also cultural attitudes in terms of using psychoactive drugs. If we don't win there, we're not going to win anywhere else. Here you can see the larger network in terms of all the stakeholders with the person at center. Person-centered care in terms of creating an environment where one become self-dependent and make their own decisions and be productive is where the primary goal is. MDHHS and the larger, and the payers play a role here, but it really takes all these other community members. Now what I'd like to do is really focus on the high parts in terms of what our strategy that's evolving and still in play right now as we're working with Dr. Wells and Dr. Pinells from who is our chief psychiatrist. But as you can see, HIT and analytics are core to all of this. Number one, reduce supply and demand for opioids. Get them out of the medicine cabinets. Do not make them available to other people. Prescribe less. Be in a position where your total daily dose of opioids is decreased or not. Do not go there at all. Because we now know that within 7 days you can start becoming tolerant to an opioid, which is much different than the way we were trained 15 and 20 years ago, where pain was described by the patient. They were given a pain score, higher the pain level in terms of someone describing that, then being at a point in time where there was encouragement to increase the dose with no upper limit. We now know that is false, and it's largely driven to misinformation put in the medical literature, and pain as the 5th vital sign, being misunderstood in terms of what was meant by the Joint Commission. Number 2, prevent addiction. Don't go there. Start with the family, having value-based discussions early on after 10 or 11, and going further from there, and resetting people's understanding of what the long-term effects of these medicines and drugs are. Identify addiction early. Then the next piece is respond rapidly and rescue at the site of an overdose, where anyone has naloxone available, and sometimes you need lots of it, especially of carfentanil, which is 1,000 to 10,000 times more potent than morphine. And then stabilize by using medication-assisted therapy and ensuring long-term therapies, which are psychotherapies based on retraining the brain, because this is now a medical condition. Neurons have decreased in size and number, the connections have decreased, and the cognitive function has decreased, where executive function and judgment are markedly impaired and take up to 2 to 4 years to repair themselves. So where do we all in this room fit into this. It's everything that we've heard today, and we can put it all to good use. One is leverage HIT wherever we can, starting with maps and finding out who's taking the medications, who's prescribing them, and are they at risk for overdose. Number two is to increase patient alerts and population level dashboards. So individual within our electronic medical record, in terms of alerts where there may be a danger signal or a risk score, and then population level dashboards. We've talked about those. Disease management software. We've been talking about that for pain and addiction. And treating this as a continuum of one and the same disease. You're using opioids. When you start them, when you stop them, and then what happens if they can't get off. Accelerating health systems analytics and research is another core pillar for our fifth strategic pillar, or core piece to our strategic pillar, and we've been talking about that all day. How do you get the information to the right place at the right time in a seamless manner without barriers? So, how do we do this? We've talked about using specific use cases to build out our applications. Reduce provider burden and improve efficiency. Critical, because doctors are burnt out and close to fed up. Anything we add to their daily chores is going to be difficult. If we have information that's there at the point of contact before they go into the exam room or before an overdose occurs by looking at analytics through dashboards from a system level, the better off we'll be. Using principles of learning systems. We've talked about that both yesterday and today. And eliminating boundaries to access those who need to make those decisions and to coordinate care, but keep the curious and the malintended out. So how do we do that? One is we have to address the current conflicting laws in terms of guaranteeing privacy, but yet at the same time being told that we have to increase transparency and portability. They directly conflict with each other, and we have to sit down and figure out the business rules. When we spoke with Genevieve Morris on Tuesday night before starting yesterday, that was a key issue across the board that we have to be able to solve and be able to solve it in a most fundamental manner, but protect individual rights. So when do we have the right to see information? When do we have the right to break glass? Are all continuing conversations that need to continue. And then leveraging telehealth. We just had a great conversation about that. And then being in a position where also, going a little bit further up on this slide, ensure scalability and flexibility to accommodate not only the large health system, but continue to push this information and be able to motivate people to broker change with themselves, with their family members, or with their friends by using personal apps. So it's everything that we've been talking about. We have a very large need for this. We need everyone's assistance, and if we stick to these core principles, we can remain together, and we can start to solve this problem and put that genie back in the bottle. So in summary, looking at root causes for the opioid epidemic are complex and multifactorial. It's imperative to shrink supply and demand for both opioids and heroin. We have to take a systemic, multidisciplinary approach to properly address this problem, focusing only on prescription opioids without addressing heroin, I think will markedly decrease the probability of success as well as changing cultural attitudes. A well-designed HIT and analytics backbone is essential, and it's going to take a village, every village here in the state of Michigan. Thank you.
Good afternoon, everyone. As I'm getting started here today, set up and ready to go, I need to give a shout out to Regina Holliday and the Walking Gallery and my fellow Walking Gallery members here today. For those of you who don't know us, we are a diverse group of 500 people around the country from all walks of life who have our stories as patients and family caregivers painted on the backs of our suit jackets. So please do, I don't want to be rude and turn my back, but please take a look at mine on break. I'm happy to share that story with you as well. So we've got a lot of territory to cover today, so let's get rolling. For those of you who don't know me, I'm a longtime family caregiver for multiple parents with dementia, an entrepreneur and an activist. But I've recently taken on a much more visible role as part of the Alzheimer's Patient and Caregiver-Powered Research Network, and we'll get back to that in just a minute. In 20+ years of advocating for my aging parents, I've pretty much seen it all. There are several indisputable truths that I've come to learn, namely that our healthcare system is incapable of dealing with dementia, and family caregivers, in fact, are the front line of defense, with few tools to assist us. My solution, out of sheer frustration, was to get involved. And one of the organizations that I got involved with was PCORI. You heard them mentioned earlier, the Patient-Centered Outcomes Research Institute. Now, I know there's at least one lawyer in the room today, so I have a disclaimer that I'm required to share with you just to make all those lawyers feel better. Some of the following slides are courtesy of PCORI and have been used with their permission. The rest of the presentation does not reflect PCORI's views or positions. Now let's talk about the evolution of PPRNs. So PCORnet is the crown jewel of PCORI. It's a network of networks that harnesses the power of the massive amounts of health information being generated in real-world settings, like clinics and hospitals. Researchers can now access these data sets. So the vision of PCORnet is to support a dynamic learning U.S. healthcare system, which we've heard a lot about today, and to enable large-scale clinical research conducted with enhanced quality and efficiency. Imagine that. A system where we're constantly asking, answering, and refining questions and improving the standard of care for patients. Most importantly, one that offers the right answers to help people make informed healthcare decisions. We created a robust infrastructure that unites clinicians, people, health systems, and all the data that's being generated from patients every day as they have their healthcare encounters. Linked up by millions of data points that were previously disparate, not just EHR data, but also data contributed by people, and invited clinicians, health systems, and patients to be part of the research process from the outset. Our goal is to change the research conversation from one directed by researchers to one driven by the needs of patients and other healthcare stakeholders. Because when you think about it, isn't this the way clinical research should be? All right, this is a goofy slide, but I blame that on PCORI. PCORnet is made up of two kinds of individual partner networks: the Clinical Data Research Networks, or the CDRNs, and then the Patient-Powered Research Networks, or the PPRNs. Our 20 PPRNs are operated and governed by patient groups and their partners. CDRNs are networks that originate in healthcare systems, like hospitals, health plans, or practice-based networks. All right, a little closer look at the PPRN. They're actually communities or networks of patients who are focused on a particular condition or disease. They work with researchers to identify the outcomes that matter most to patients. Paradigm shift there. Look at the diversity of diseases and conditions represented by these PPRNs. I've highlighted the Alzheimer's PPRN because I'm going to take a deeper dive into how this one works. But know that our sister PPRNs are doing incredible work as well. And I know Erin is going to be addressing IAN, which is the Patient-Powered Research Network for Autism. So stay tuned for that as well. So here we go. And I'm going to start by level setting why we need this important network. I'm going to test your knowledge of Alzheimer's for a moment. All right, did you know that today Alzheimer's is 100% fatal? There is no cure. There are no reliable treatments. We don't have survivors. And it's the only leading cause of death still on the rise. It's also an epidemic. By 2050, roughly 14 million people in the US will have this disease. And the global numbers are even more frightening. And keep in mind, this is just the number of people with Alzheimer's disease. This does not include those with other forms of dementia, numbering close to 100. Yes, you heard that right. There are nearly 100 different types of dementia. So we've had a pretty bleak picture to paint until recently. Alzheimer's research is seriously underfunded compared to other major diseases like cancer and heart disease. And people with this disease and their families have largely been disconnected from research. We don't have people flocking to clinical trials. And this is especially true of women and minorities. I'm going to pause and let you ingest some of the statistics on this slide because they are frightening. The imbalance of minorities and women participating in clinical trials, the very same people who bear the brunt of the cost and care for their loved ones with this disease, is simply unacceptable. Very frightening numbers there. And our friends at RAND recently confirmed what I already knew, that dementia is the most expensive disease in America, again, eclipsing cancer and heart disease. On a personal note, my husband and I have spent more than $250,000 to support multiple parents with dementia. Basically, we gave away our retirement, and we still got one more parent left. So by 2050, we're talking about GDP, I've heard that a couple times today. By 2050, the cost of this disease will eclipse $20 trillion. We can have some big conversations about GDP with this number. $20 trillion by 2050 to care for everyone with Alzheimer's disease. So all this to say, we need a full court press. We need new approaches to research. We need those who suffer with Alzheimer's, along with their family caregivers, participating as research partners. So I am thrilled to introduce you to the National Alzheimer's and Dementia Patient and Caregiver-Powered Research Network. I'm going to use shorthand to refer to this new entity from now on. So when I say Alzheimer's PPRN, they're one and the same. Every now and again, you got to have shorthand. There are 4 partners involved in this effort. They're led by Us Against Alzheimer's and the Mayo Clinic, along with our friends at UCSF and the Brain Health Registry and the University of Florida. So there are many more collaborators. As you see here, this list expands, and it will continue to grow over time. So the goals of this project are several-fold. You will hear me talk a lot about clinical trial recruitment in this presentation, but I also want to emphasize the importance of the cognitive well-being of family caregivers and the importance of brain health for each and every one of us. The Alzheimer's PPRN will be a one-stop shop for brain health registries, virtual studies, and clinical trials. A lot of this well underway at this point. It will be virtual and mobile. We will be focused on recruiting minorities and women, as I mentioned before, and we'll also be focused on the impact of family caregiving. And I'm sure, show of hands, how many of you care for somebody? How many family caregivers in this room? That's what I thought. A lot of you here. Good. Awesome. So the Brain Health Registry that I mentioned a moment ago at UCSF is the cornerstone registry for this project. But others are joining the team, including our friends at the Banner Alzheimer's Institute, Cleveland Clinic's Lou Ruvo Center, the Alzheimer's Association and Trial Match, and Weill Cornell. Lots of great partners, lots of great registries. So to facilitate this conversation, we're working on 4 cornerstone projects. Let's look at each one in turn and how we're using technology to support it. Recruitment into registries and clinical trials is going mobile. We want the right patient in the right trial, and we're going to keep them engaged. If they don't qualify for one study, we have another for which they could be a great match. If their clinical trial comes to conclusion, we have other places for them to land. They will receive feedback. They will not be left wondering if their participation mattered. Now, part 2 of the Healthy Brain Study follows a very successful part 1, where the cognitive health of family caregivers was measured for the very first time. Because we understand the enormous stress these caregivers are under, we will be offering a virtual intervention to those caregivers who meet a certain threshold for depression, addressing this for the first time as well. So we're also assembling a group of 1,000 advocates to participate in critical early adopter activities, focus groups, mobile health app testing, and online registry use. Their feedbacks can be critical to this process. You too can be a member of the A-List 1000. And we also have patients and family caregivers already working on podcasts and blogs, telling their stories, chronicling their experiences as they participate in clinical trials. Very important. So what makes the Alzheimer's PPRN different? So we've touched on these already in different forms. Family caregivers, key research participants here. Because remember, we frequently speak on behalf of people who can't speak for themselves anymore. Data is shared back to the participant, and then the continued involvement and engagement of a participant after a study or trial ends. Very important. So our goal is to change the culture of clinical trials and integrate the voices of patients and family caregivers into drug development and beyond. We're truly bringing Alzheimer's research to the people. We're going to be engaging with folks on multiple channels. I hope some of you are busily tweeting out some of this talk today, because we're going to see you online, we're going to see you in the media, we're going to see you in the community. I'm going to spend a little time on this slide because it deserves its due. This is what we want to accomplish as we reach out to people. First, we really need to take the mystery out of the words clinical trials and registries. Make them part of the dialogue being held at dinner tables around the country. We need to remove stigma and distrust from the research process, and you all know what I'm talking about. We have to earn the trust of skeptical patients and family caregivers along the way. Third, we need to embrace cultural differences in how we present information to ensure that all families are comfortable with and want to participate in what we're doing. Fourth, utilizing diverse platforms to meet people at the technology modality they are most comfortable with. And finally, focusing on the health of family caregivers and the importance of their voice in finding new treatments for Alzheimer's disease. And a quick word about the bigger picture, because there is one. The Alzheimer's PPRN is actually part of a larger effort that's unfolding as we speak. It's called Galaxy. This is going to be a hub of activity for patient-centered dementia research. Please go find out more. I know you guys got your devices rolling as I'm up here talking. Go to galaxybraintrust.org, find out more, because I have big news to share with you today. We have just launched 2 new tools thanks to our friends at Rubric and Antidote. These are designed to help people learn more about clinical trials. Folks may never have heard of clinical trials before. We're going to teach them what it's about, and then we're going to match them to an appropriate clinical trial. Again, go to galaxybraintrust.org to learn more. Equally important, I need everyone in this room to participate in the Brain Health Registry. So again, go to, in this case, brainhealthregistry.org, set up a profile, fill out the questionnaires, and play the brain games. They're a ton of fun, and unbeknownst to you, you're going to help move brain research forward. And we need everybody. We need healthy people. We need people maybe who aren't so healthy. We need everybody participating so that researchers can learn. And in closing today, I encourage you all to not only learn more about the initiatives I've discussed here in the past few minutes, but take a few moments to visit the Healthcare Activism and You booth. That is a special project that we've just launched, and the idea here is to bring information, free information to you all about organizations and initiatives in which you can be involved. That includes PCORI and PCORNet, that includes the Alzheimer's PPRN and others. Again, visit the booth and please pick up one of everything on the table, mostly so I won't have to take it home with me in my luggage, but these are all things that you all need to be involved in. Share it with your friends, share it with your family, and help us make a difference. Thanks so much. Here you go, sir.
Good afternoon. Thank you very much, my dear friend MaryAnne. A lot of things that MaryAnne shared I could equally echo in the autism community. MaryAnne did point to the fact that we're involved in some of the PPRN activities. I'm going to try and briefly share and get us caught up to date on a foundation that I helped form called MARC, the Mutual Autism Research and Care Community. Oh no, different controller than earlier. So very briefly, MARC was incorporated by a number of families whose children are affected by, one or more of their children affected by autism. We actually just turned a year old. We were founded by parents, for parents. All of our board members are parents of children on the spectrum. And our vision was to provide tools that we know that we can build as information technology professionals, clinical informaticians, and so forth, that would improve lives of people who have newly diagnosed children on the spectrum. That's our first priority, and then looking forward, how do we improve outcomes, care coordination, and ultimately enable data donation for those families that are comfortable with that. But our primary motivator, we are trying to be the change that we want to see in the world from the earlier presenter. We feel an obligation to be part of the solution. And we think that what we're working on is a grassroots effort, that we have a particular disease vector that can benefit from a lot of the massive investment that's happened. But to get the solutions that we're looking for, that we believe will help our families the most, we have to be part of the team that's pushing that rock up the hill. You know, I've been coming to conferences and speaking about consumer access to health information for quite a while, and whenever I present to a crowd of 500 or more people, I was always approached afterwards. You know, I have a son on the spectrum as well. How can I help? You know, what can we do together? And that was basically where the MARC came from. You know, different people with different assets, you know, expertise, legal expertise, health information technology tools, consumer apps, knowledge of the intricacies of being able to securely exchange health information between covered entities and non-covered entities, which is my little contribution. So, you know, because of the prevalence of the disease, it's not that I did anything extraordinary. I just talked to enough people, and I found, you know, docs that have children on the spectrum, researchers with children on the spectrum, all wanting to try and get engaged and find ways to donate back to families that are affected by the spectrum. We're half collaborative, half, you know, mutual aid society. Folks in Vermont, folks in Minnesota, Texas, and hopefully soon Michigan are all participating in different things, and we're reusing and doing group purchasing and whatever we can do to help shore one another up, with the ultimate goal of making a consumer-controlled health information application available to families affected by autism for free. And two key things, as indicated by our name, is to help make it easier for families to coordinate their care, work with navigators and social services to realize the benefits that they're entitled to the most, and really pursue benefit determination. We had a summit yesterday with a lot of families affected by autism here in Michigan. And it's just painful to hear people talk about the process of getting qualified for different benefits that they're entitled to, either through insurance or through social services, and the repetition of having ADOSs performed and elimination of other conditions before you become qualified. When if we had a really healthy longitudinal health record for that child, we would be able to get them into the services that they qualify with the most for as quickly as possible, which is really critical for newly diagnosed kids. Of course, we talk a lot about, it's not enough just to give people their data. We need to give them things that make engaging with that data useful to them. As a parent with a child on the spectrum, there's a number of things that you try to measure to report back to your physicians. You are the only eyes that are on your child all the time. So tools that help you record how frequently they attempt to elope, how often are they self-injurious. Number of these types of tools are important to our vision of a consumer-controlled app that will be engaging to families. So we're really mindful of some of those advantages. And ultimately, for families that are, there's a period of time after the initial diagnosis, nobody really teaches you how to get accustomed to it. You just have to go through that process with your family. But at some point, you can start thinking about how can I contribute what we're learning from this experience so that the next generation of kids have better outcomes and better science to improve their experience. So ultimately, we want to enable families who we help aggregate their EMR data, help them aggregate their patient-reported outcomes, and enable them to share it for research purposes. So within the next 10 years, hopefully we'll be able to stop this knowledge loss that we generate as a society and start creating a learning health system that benefits children on the spectrum and many other diseases. The principle about what we're working on is it's all consumer controlled. Lots of folks have been up here today talking about a multi-stakeholder engagement. From our perspective, when we're talking about individual care coordination, individual health decisions, it's really up to the consumer about what gets shared and for what purposes. We're just trying to make tools available so that they have all that data, so they can be responsible and contribute to improvement in their own care. Why Mark? Honestly, I think grassroots are the only roots for some of these things. There's nobody lining up at my house when my son was diagnosed to help me find out how to improve his outcomes. I think that's true for folks who are trying to help Alzheimer's folks. It's amazing that there are programs that we just don't know about. So part of the process is matching people up to the programs that state and county and federal programs support. So social entrepreneurship is another part of this. Not that I could make tons of money doing what I know, but I would rather apply it to doing good. And I think a lot of the people that get involved in Mark and some of these programs are more interested in the outcomes that we're building towards than making a lot of money. And there's no VC investment in trying to figure out how to improve outcomes for a very niche population like families suffering from autism. And I think Alzheimer's to a large degree is marginalized. It's much more easy to make money on concierge telehealth services and some of the other things that we see as far as wearables and so forth than really tackling high-cost, complex diseases. So we have to be the change that we want to see in the world, and that's why we formed Mark. I hope that's helpful. Bye-bye.
Well, thank you to all of our speakers. I'm sure we have a time for a few questions before we go to break. I see someone over here, if we can get a microphone.
Hi, I'd like to tell you that you did a great job in your presentations. I formerly, before this job, dedicated 13 years of my life to research. I have several publications from those. But, and the organizations that you work for are wonderful. I would like everyone in this room to know that you can go to clinicaltrials.gov to learn about research in other aspects, every condition that you can think of, because it really is the future for our healthcare to move forward. So that's what I wanted to mention. Thank you.
Completely agree, and hopefully, as we build these applications that are specific and sticky to families, that we'll be able to integrate some of their health information if they like to help identify trials that they're eligible for.
And I got a comment and say I'd love to see clinicaltrials.gov may be a little more user-friendly. So I'm waiting patiently for that day because so much of what the work that we do, the back end of Antidote, for example, is clinicaltrials.gov. They're pulling current clinical trial information from clinicaltrials.gov, but it's just such a nasty website. It needs help. It's a start.
Hi, I'm Julie Griffith from Blue Cross Complete, and my question is for Dr. Neff. So since housing is an area in the Department of Health and Human Services, and it's, I think, very key to recovery from addiction, I'd like to hear your thoughts about what the plan might be to connect addiction services to the Housing First initiative and not have situations where women with children are kicked out of housing because they had a dirty urine, for example.
I think you bring up a very good point. Social determinants are primary drivers in terms of health outcomes. And that applies to those who suffer opioid addiction or in other forms of addiction. So we've worked, and I know that several areas in the department are continuing to work to find ways to improve that. There's particularly a FUSE project that is in the Kalamazoo area, sponsored by the folks who are driving the community needs assessment and strategy through Bronson. And they actually are going through a series of key learnings in terms of how to keep people engaged in their housing so they can sleep well at night, eat well, and then try to return them to some form of therapy where they can start working beyond their craving and then this incessant need that I've got to fix this pain of withdrawal before I do anything else. And so if they don't get proper food, nutrition, and shelter, then it makes it infinitely more difficult. So I think we would all agree with you. That and other social determinants are of highest priority.
We know we're leaking into break just a little bit, but these are subjects that touch everyone. So we'll have time for just another one or two questions, please.
Hi, my name's Reed DeYoung with Medical Advantage Group. My question's for Dr. Neff regarding Suboxone being available for cash patients. I'm a criminal justice undergrad, and I just wondered what the cost was of Suboxone relative to heroin, knowing that heroin's increasing in availability and it's one of the most addictive, lowest cost drugs out there.
Sure. I think there are a number of websites that you can go to if you're a cash paying customer. GoodRx is one where you can actually shop around local pharmacies, and there's a high degree of variability in terms of what cash coupons may be available. So I've seen it as low as high 20, low 30 for a 15-day supply, and I've seen it as high as $250. So it's one good application in terms of using those type of apps because you actually can find a pretty decent bargain. In terms of those who are using Suboxone, I know that at Medicaid we require that provider be enrolled and that the provider accept these type of patients, and that we're trying to steer people away from being overly manipulative of someone in need in terms of and focus more on getting patients the medication that they need. So.